afternoon, everybody, and welcome to this webinar on case study insights, diagnostic ultrasound, and shockwave therapy for enhanced MSK outcomes. And today we are joined by specialist physio and clinic owner of the Physio Studio, Andrew Creaney. And here at PhysioQuip, we supply specialist MSK technologies and provide several education resources. And yes, we do work with both the diagnostic ultrasound and shockwave therapy, which Andrew has in clinic. So in today's session, Andrew is going to cover how he's incorporated these technologies into his clinical practice, and specifically showcasing some patient case studies, which is going to be great. So following Andrew's presentation, we will do a short Q&A. So we will cover some of the pre-submitted questions that we have received through. And if you are listening live, then please feel free to submit any questions that you do have in the Q&A tab, and we can get to answering those as well. So with that, I'm going to hand over to Andrew for the presentation.
Thank you, Katie, for the introduction, and hello, everyone. And thanks for spending your lunchtime or wherever you find yourself on the webinar today. Yes, this case study is just some insights into case studies on my journey with diagnostic ultrasound and shockwave therapy. And we're going to talk a little bit about enhancing some MSK outcomes. I'll be brief with this, but we are the Physio Studio in Dungannon. That is just on the west side of Lough Neagh in Northern Ireland. So we're about a 45-minute drive from Belfast. This is our team: Janice, Stuart, myself, Emma, and Hannah. Dungannon's in County Tyrone, the biggest county in Northern Ireland. Famous exports include Darren Clark, snooker player Dennis Taylor, and Quality Street tins. So I have your attention now. And I know that Quality Street tins have got smaller. That's nothing to do with us. We're just told what to do. Okay, so just a brief timeline about me. 2013, I graduated from the University of Ulster with a physiotherapy degree. Commenced work in the NHS in 2014. I kept working there, and then I started my master's in sports physiotherapy through the University of Bath, graduating in 2019. Moved into private practice then, and then in 2020 I opened the Physio Studio in February 2020. So we opened 6 weeks, and then we had to close for a lot of months after that because of the COVID pandemic. 2022 I did my first introductory course into diagnostic ultrasound with the SMUG group. And then 2023, I started the PG Cert and mentorship program again through SMUG. And then in the summer of last year, graduated with the PG Cert in musculoskeletal ultrasound. Bought my ultrasound equipment at the end of 22, start of 23. And then my radial shockwave device was before that. I think it was 2021 from memory. This is a curve that comes up a lot on conversations about your education into diagnostic ultrasound. It's called the Dunning-Kruger effect. Basically, you start on the left-hand side and you soon feel that your confidence is getting very high. Well, that's a very dangerous place to be. You're incompetently incompetent, if you like, followed by the valley of despair where you feel like you know nothing. A bit of self-reflection. I think I'm coming up the curve. Just somewhere in the middle there. It depends on what you see, but always learning on this journey. And I have to say the ultrasound community are very, very supportive. If you get a good few people around you as well, can assist you on your day-to-day practice. So we'll just jump straight into a few case studies that I've came across. These are all real patients from the clinic, and they've been in the last 3 months. I have some pictures included. They're not the patient's faces, they're just there for illustration purposes, but they very much are their scans. Okay, so we're just talking about a couple of shoulder cases that I've seen in the last few months. We work over from the left. We've got a 57-year-old retired teacher, with a 1-year history of shoulder pain, aggravating factors, very typical overhead movements, lying on the flatted side. Objective assessment, you could see that he was painful above 90 degrees of abduction, and he could manage to 150 degrees. He did not have a capsular pattern, and his cervical spine was clear. Second patient was a 34-year-old female personal trainer. She had shoulder pain after her fall. She had an x-ray which was clear. Similar aggravating factors to our teacher there. She had a painful abduction arc. Again, C spine was clear. And then lastly, our 29-year-old construction worker with his gym being his main hobby. He had 6 months of shoulder pain with a painful catch, aggravated by the usual overhead activities. He had full range of motion, a positive impingement cluster, and he had some pain at the end range of abduction. Clinically, he thought that all of these were suffering from relatively similar condition in the diagnosis of subacromial pain syndrome. So then we go on to your ultrasound scan. So patient number 1, which was the teacher, and these are all supraspinatus tendon scans. We could see there that he had quite a large calcific tendinopathy. Case number 2 was the personal trainer had the fall. She had a subacromial subdeltoid bursa distension. And then our third gentleman who was into the gym, construction worker, he had normal image findings. Nothing was there to be found. All the other parts of the scan were normal, thankfully. So we have all of a sudden 3 patients with the same clinical diagnosis, but as we can see through our ultrasound, that the diagnosis has actually turned out quite different. And so has our treatment pathway as a result. Patient number 1, we discussed his options. He was quite impatient. He wanted to get back to things, and he actually opted to get a referral for a barbotage procedure, which was very effective. He reported a full recovery for 6 months, and then his symptoms gradually returned. We did rescan him, which showed that he had a smaller recurrence of his calcific deposit. And at this point, we discussed the options. We thought because it was smaller and his symptoms weren't as severe, that we would try radial shockwave therapy on him. So we did 4 sessions over 6 weeks, and he felt that his pain had improved. He regained full range, and he felt like he did after the barbotage initially, that he had full recurrence. He had full resolution of his symptoms. 6 months later, he remains symptomatic, and we scanned him again. There was no further calcific evidence on ultrasound. That's not always the case, which we'll explore in the next slide, but we'll come to that in a moment. Patient number 2, really wanted just to rehab this one, didn't want to go down the injection route. However, patients make their choices when they're given all the information, and she did opt to get referred out of her clinic for an ultrasound guided injection into her bursa, which was an excellent response, and she made a very quick recovery. Patient number 3, very physio-appropriate, still under the diagnosis of subacromial pain syndrome. He was starting a rehabilitation journey. After 12 weeks, he had resolution of symptoms. So I just wanted to talk about, how clinically we can have a similar diagnosis, but when we delve a little bit deeper into the details, we can find a bit more information, and that was achievable with our diagnostic ultrasound in this case. Just to pick up on the calcific tendinopathy, as you know, he did get the barbotage first, but then he had some recurrent symptoms. Good evidence base for radial shockwave therapy on calcific tendinitis. The study showed that it was successful in outcomes and also reduced the size of the calcification. However, this is not always the case. A second study showed that improved symptoms. However, the deposit remains unchanged in the size in most patients. And then this study studied 20 randomized controlled trials. They compared shockwave therapy with placebo and showed the shockwave therapy was consistently better than placebo in decreasing pain, improving function, and helping with the reabsorption of calcifications. I think we're all very familiar, especially in the physiotherapy world, that imaging can have poor correlation to symptoms. I think these studies touch on that you can still have calcific evidence, but you can be functioning much better. In our case, thankfully, the calcification was removed, and it showed that it was removed on the diagnostic ultrasound scan, and thankfully, no recurrence on our last review. I thought I'd add some of these things in. It's not always plain sailing. Like any learning, you do get confused sometimes. You have to draw on help. So I've added in the logo at the top of the left. This is throughout some of the slides. It's a curveball. So some of our, I got some curveballs in my journey so far. This is one of the first things if you're learning a diagnostic ultrasound, you'll come to in the shoulder. This is cross section in the bicipital groove. It's the biceps tendon in the middle. and it's called power Doppler. So we see some hyperemia or blood flow on power Doppler. This is the long-headed biceps tendon. And this confused me because I thought, oh, there's two bicep tendons in there where shouldn't be. And you can see it over in the right-hand image there. What we have was the long-headed biceps where it should be. And this was an aponeurosis slip of the supraspinatus tendon that appeared to be causing some bicipital groove tenosynovitis. Good studies in this now. It can be a coincidental finding in many shoulders. Some studies report up to 50%. Some studies saying that we would maybe should set up now and think about this as it can sometimes be pathological, not always, but sometimes it can cause some problems in and around there. So that was some shoulder issues that I came across in the last few months. Bounce down now to the ankle and heel pain, some studies that we've had in clinic. So we'll try to do a diagnosis journey here together. So 56-year-old female, 6-month history of left heel pain. She had some secondary lower back pain, so we did send her for a rheumatology review. Bloods came back normal. HLA B27 was normal. No psoriasis history, no inflammatory bowel history. So we ruled out a rheumatology point of view. She was worse after exercise. Her visa A sedentary score was 24%, so very low, and her pain at worst was 9 out of 10. So this lady was in a lot of pain. Objectively, the Achilles swelling was noted. There was pain on Achilles palpation, which is a very sensitive test for Achilles tendinopathy, at least 85% sensitive, and she was unable to single leg heel raise. Now you're all thinking the same. I said, okay, this is a very likely Achilles tendinopathy. This was before we scanned. She was actually known to the clinic before. So we commenced on a very, I hope you like to think, very standard rehab program. We started on a loading program. There's very good evidence for radial shockwave in mid-portion Achilles tendinopathy with reduction in pain and function. So we did 4 sessions of radial shockwave. After 12 weeks, her visa A had increased to 44%, but pain was still 7 out of 10. So this was still a very sore patient. So we scanned her. You've got the Achilles sitting above Cager's fat pad. This is calcaneus to the right of the picture. Again, we see some hyperemia and power Doppler, which what I've learned in my learning journey so far is that Doppler can be a little bit controversial, can't it? It doesn't always mean that there's an inflammatory systemic response. It can maybe be that they've walked in quickly from the car park. But in this instance, combined with everything else we see there, we've seen a fusiform swelling of the Achilles, a loss of fibular pattern, some hypoechoic regions. And I thought, no, I'm pretty good here with this diagnosis, Achilles tendinopathy. But then my eyes just drifted down just below the Achilles. And we can see there what is a very distended, very angry looking retrocalcaneal bursitis. So that changed how we thought about this case. And this was one of the questions actually I seen came up in one of the pre-submitted questions. What do you do if shockwave doesn't work after 4 to 5 sessions? In my experience, some might disagree with me on this, but in my experience, you have to rethink your diagnosis. If you are certain that it is that chronic tendinopathy that's not responding to a combination of loading and shockwave, which the evidence has shown to be the best treatment program for Achilles tendinopathy mid-portion, well, I had to rethink my diagnosis. And then when I went and looked with the diagnostic ultrasound scan, we seen this retrocalcaneal bursitis that was looking very angry. Again, explain the options to the patient. You're going to think I'm very injection happy. I'm not. I don't inject personally. So, and we did explain that this bursitis may be a pain causer in her pain journey here. And she did opt to go for an opinion on an ultrasound-guided retrocalcaneal bursa steroid injection, which evidence shows can cause a good short-term decrease in pain. She was counselled on the tendon rupture. That is a possibility. Thankfully, it's a low possibility, but she did opt for the injection. So now we've rethought the diagnosis. So we've got Achilles tendinopathy with a retrocalcaneal bursitis. We've added in a different treatment in an ultrasound-guided steroid injection. Her visa A sedentary. After 6 weeks, shot away up to 74%, so much more functional, and her pain went down. So I suppose I'm showing you a case that I got wrong, essentially. Initially, I treated her for 12 weeks for Achilles tendinopathy. She wasn't getting any better, and I had to rethink the diagnosis. And at that point, we did the scan, and then that's where we seen the bursitis. A little curveball. So this was a 19-year-old Gaelic footballer. Came in with an inversion injury to his ankle. His ATFL, AITFL, the calcaneofibular ligaments were normal. They scanned normally. This is his perineals in cross section, and we've seen here a hypoechoic swelling in the superior retinaculum. Hopefully this comes up. This is perineus brevis. You can see this bright wine hyperechoic lateral malleolus. And if you just look above the malleolus, this is passive inversion, and you can see there the dislocation that he was experiencing of his perineus brevis. And this was his chief symptom. He was in pain, and every time he inverted his foot, he had a dislocation of his perineal tendon. He got surgery. He was sent for surgery. He got a fiber tape anchor system to superior retinaculum. This was actually his post-procedure images, which, to be completely honest, I found hard to I find it hard to understand what had been done, but I obviously had the retinaculum repair, and you can see some acoustic shadowing coming through the perineal tendon in long there, with the fibula below that. Doing very well, still getting rehabilitation. He's just out of the boot. The dislocation has thankfully stopped. He is pain-free, and we're just going through the rehab journey at the moment. That was my curveball for ankles, and that was back in October. Okay, so a few more cases for you. Thanks for your attention so far. Here we have a 19-year-old Gaelic footballer. He had acute left hamstring injury, which was a sudden onset during deceleration. Came in 2 days after his injury. He was very antalgic with his walking. No bruising was noted in the posterior thigh. Objectively, very painful, pain inhibition and weakness. Unable to long lever hip extend against gravity, and he could initiate some knee flexion and prone, but he had to stop due to pain. This was a sore person. We did ultrasound right away. This is cross section, left versus right. SN sciatic nerve, long-headed biceps femoris, and the semitendinosus. So we're looking at the conjoint tendon here at the proximal hamstring. We've seen this anechoic disruption of the muscle fibers here of the long-headed biceps. So we knew that we had a hamstring injury here. Just here. I wouldn't rely on ultrasound completely for the diagnosis or grading of hamstring injuries. And the study to support that is very useful in primary evaluation. It was in my office. It was there. There's no radiation. I could do some dynamic tests with it. I could get that information straight away. But the best thing I could do for this player was to onward refer him for an MRI to get grading. So that's exactly what we did. And this was the MRI report. So I'll not read through it all. That will bore the life out of you. I'll just skip through. Oedema arising 6 centimeters distal to the ischial tuberosity. Primarily the long head of biceps femoris with the 2 by 2 centimeter hematoma present in the intermuscular plane. Measures approximately 4 centimeters in length, but because it was only a small area of continuity and transverse, with it being over 50% of the cross-sectional area with no retraction. And this is a high-grade tear, and it was graded or classified as a BAMIC 3C. This player did conservative management, rehabilitation for 3 months. We collected data on the way, normally with hamstring testing. We're lucky enough to have some of the equipment in clinic here, along with some functional tests as we went along, just to progress him through his rehab journey. And he's doing great now. He's back to competitive sport with no recurrence. We'll go for anterior thigh now. So this was a 15-year-old footballer who presented with left thigh pain and weakness, but it was only with forceful kicking. So it was only when he was kicking the ball as hard as he could. And he was a centre back, so he did some long balls up the pitch. So he found it, but he was still playing on despite the pain. Subjective history, he was a bit vague, but he thought that 5 months ago he did feel a pulse sensation in his left thigh, which did force him off at the time, but he took 2 weeks off and then he came back playing with that niggle like we see many athletes doing. When he came in to see me, he was post-pubescent. His knee and hip were full range. He did have firmness on the palpation of the mid-proximal rectus femoris. And we did handheld dynamometry of knee extension in sitting. Now, he is a left-footed player, so we would expect some left-sided dominance in his test here. But actually, he was reporting pain during the test, and we can see a 22.5% differential favouring the right, which was unusual. He's a strong boy for his age group, and the right leg 88th percentile. Not a bad result in the left, but with this being his dominant leg, we knew something was up here. What we've got is a cross section of the anterior thigh here. We've got the hyperechoic femur at the bottom of the image, vastus intermedius, and then rectus femoris here in this compartment here. It's just scanning distal to proximal. What we're really looking for here is a little hyperechoic teardrop tendon. So this is the contralateral side here, which is the indirect tendon of the rectus femoris. What we've seen here was absence of that on his left side, and we've seen some a little bit more hyperechoic scar tissue formation deep into the rectus femoris, which we diagnosed as soft tissue scarring from a previous indirect rectus femoris injury. That player is on a rehab journey at the moment. Now we feel the need to go conservative for this one. We just think he has never rehabbed the original injury, and we're doing data as we go along. So again, nice to have the equipment. And one of the pre-submitted questions there was explain more about the outcomes related to sports if possible. Yes, we've got the diagnostic ultrasound, which really helped us there with the diagnosis. When you have an athlete going through the rehab journey, they like to know, are they hitting their goals? Do they need to work harder? Do they need to work less hard? We find the data very helpful for that. For that one, we're keeping it very simple. We're using handheld dynamometry for 90 degrees knee extension in sitting. We're doing isometric squat hold. For that, we use a K box with force plates on top of it, and then a shoulder strap to look at his iso squat. And then we're going to look at force reduction in his jumps as well. So we'll do counter movement jump, limb asymmetry, and then we'll do single leg jump. We'll look at jump height and impulse there. We keep the data simple. 4 or 5 data points is we feel all we need in a 14-year-old amateur footballer there. And we'll guide our rehab journey and also keep him interested as well. Okay, jumping around the body a little bit here. I really should have started from the top and worked down, but here we are. So a few elbows that we've seen. So we're back to our case study. Real patient, 59-year-old table tennis player, 4-month history of right lateral elbow pain, aggravated with his table tennis and gripping, all very typical here. Swelling of the lateral elbow on objective assessment, still carrying full range. Positive Mills and Mausley's tests, and his grip strength was well down, right side being his dominant arm. Again, what expected to be more. Test was limited by pain and weakness, 52 kilos versus 26 kilos. No fancy equipment there, just the typical hand grip, handheld dynamometer there. So clinical impression, lateral epicondylitis. I said, don't need a scan. This is all very simple, but I scanned him anyway because I had it there. Why wouldn't I? So it did show a thickening of the common extensor origin. However, what we did pick up on was an intrasubstance tear in his common extensor origin there, about 6 mil by 3 mil or so. Why did that help me? It helped me because, probably like most of your patients, he was dead keen on a steroid injection, which is very poor evidence for now in the management of lateral epicondylitis. So because we can obviously see an intrasubstance partial thickness tear there of the common extensor origin, this was highly discouraged and he did not get one. Instead, he was actually started on a loading program. I chose not to shockwave this patient because of the partial tear. I just wanted to go a little bit more conservative than that. So we started him on an isometric, progressing into eccentric rehabilitation protocol. However, we all see a lot of lateral epicondylitis in clinic, I'm sure. Good evidence for radial shockwave therapy for lateral epicondylitis in chronic cases, and when combined with loading. This is my little curveball. I've got a second opinion, this one pending. So this was an 18-year-old jiu-jitsu player who 6 weeks prior to the scan had a forceful rotational injury of his elbow. of his right elbow. There was a known coronoid process fracture already from an X-ray in his fracture clinic, which is the image on the right side of the screen, which we see. But in the long section of his right elbow, we've got this hypoechoic line extending from the joint line there. To me, that looks like a radial collateral ligament tear extending into the extensor carpi radialis brevis. I wanted further opinion on this, which is pending. It's my little curveball. Maybe someone will refute these findings when I'm reporting. But we have referred this back to orthopedics to consider an MRI to check for the presence of a radial collateral ligament tear. Quite a new one to me, don't come across them too often. That's why I've reached out and got a second opinion on this. Okay, we're getting through rightly. So, case study of the knee. Had a 20-year-old female hockey player. She had an increased load, so she played summer football and then winter hockey with no break. Sharp increase in load in pre-season, coupled on a chronic history of anterior knee pain. And she was getting this anterior knee pain, very typical. Pain with single leg squat, worse with heel elevation, and no traumatic mechanism of injury. So this was her scan findings, showing this hypoechoic swelling of the proximal patellar tendon. So we're dealing with patellar tendinopathy here, a chronic one. We did use shockwave in this. We used it over 4 sessions, which was over 8 weeks, coupled with a loading program. You're getting the trend here. Shockwave is rarely used in isolation. We're still clinicians, physiotherapists at the end of the day, and we know what a loading program is generally the best form of rehabilitation. But good evidence to support the use of shockwave therapy with patellar tendon. Functionally came on well, did a lot of the functional tests that we talked about with our previous anterior thigh patient there, and handheld dynamometry and our jump test using the force plates. However, diagnostic ultrasound is a poor prognostic indicator of recovery in patellar tendinopathy. So what I mean by that is they can be functionally improving, but if you scan them, their scan might look quite similar to the first session that they were in, which was the case in this one. Actually, she was making great functional gains and her pain level was well settled. But her scan was a little bit behind the trend of her recovery. So it's just worth keeping that in mind as well. That great for diagnosis, but in the case of patellar tendinopathy, poor for prognosis. A little curveball on the knee. Got a video here. We're in the lateral knee here, starting at the proximal tib-fib joint. Oh, sorry, I don't know whether you guys are getting that or not, but my video just slowed up a lot there. What we've seen was a multiloculated ganglion cyst with a neck arising from the proximal tib-fib joint, and there were some cortical irregularities at the proximal tib-fib joint. Apologies, this was a 39-year-old football referee and engineer who reported a deep, severe pain down the anterolateral compartment of the lower leg running after running, and the pain would have stayed around for 2 or 3 days. Rest helped, but as soon as he went back to any form of running, the pain came back. So this was diagnosed as a cyst arising from the proximal tib-fib joint, which occurs in less than 1% of knee pain cases. He was referred to sports medicine, who scanned and agreed with the findings and decided to aspirate with 3 ml of the thick fluid removed. A little bit of depomedrone was injected, and he had complete resolution of symptoms. The plan going forward for him, no return of symptoms yet, this is quite fresh. This was only in January this was picked up on. He got the aspiration at the end of January. 2 weeks later, he's back doing everything with no symptoms. However, if symptoms did return, I think we would MRI, specifically looking into the proximal tib-fib joint. Sports medicine doctor said that if anything was found there, they may consider a proximal tib-fib joint injection. Again, I don't inject, so I'm happy to be make their case on that one. That was just an overview of some cases. I say thank you for your attention. Getting more into ultrasound now. Yeah, again, I'm not that long doing it in the grand scheme. I first picked up a probe only 2 years ago, so I'm not a novice. I was a novice not that long ago. I'm just not a novice, but still there. So what would my recommendations be that I've just came through the process of getting a PG cert in diagnostic ultrasound? First thing would be was to try it. So to book into a reputable introductory course. I would say try not to take shortcuts in your machine purchase, and this is the biggest question that I had when I was starting out in my journey, and I'm sure many of you have as well. If you are, what machine do I buy? When you go on and get into Google, there's a lot of machines out there with a vast price range ranging anywhere between £3,000 and £103,000. I have this one on the screen actually. I have the Opinion eCube 8 Diamond, which I'm very happy with. It's a cart-based system. I think one of the biggest questions you might want to ask yourself is whether you want a laptop portable device or are you generally in the same room all the time and can do with a cart base. Get yourself a good mentor. I did the mentorship program through Smug. I find it very good. Your learning never stops. I found ultrasound can bring a lot more questions to your clinical assessment, but also more answers as well. Just thinking back to that Achilles tendinopathy case and that lateral knee pain case, I would not have been able to diagnose a proximal tib fib ganglion, which was extending 12 centimeters down the anterolateral compartment. There's just no way. I've really enjoyed it. I genuinely enjoy learning ultrasound and introducing it into the clinic. It is transformative to your practice. And physiotherapists, it's great that we've extended scope for the use of point of care ultrasound in clinics. And the money side of things, I found that the total setup costs were somewhere between £25,000 and £35,000. That was based on my machine purchase, the learning, the PG cert, the mentorship, and the travel. I suppose maybe for me, coming from Northern Ireland, flights, hotel, the rest of it, maybe just added a little bit more on. And that was based on my purchase again. You could be looking to increase your machine purchase, and you might be going up towards the 67 there plus. So lots of variety. For shockwave therapy, my top advice would be know your indications and contraindications. It's certainly not a replacement for rehabilitation, and generally best used in combination. Have a business plan in mind. Purchasing these technologies is a big decision for a private practice, especially a small one like ourselves. I suppose, yes, it's always great to improve patient outcomes, and if that's your first port of call with running your clinic, I'm sure you're doing very well. But secondary, it's always good to have that little business plan. Are you going to get new referrals? What are you going to charge? How are you going to introduce it into your clinic? It has been very beneficial to our patient outcomes. You need to know the patients you want to use it on. And it has generated more patient referrals from other clinicians who maybe don't have shockwave therapy. A straight comment here. When it works, it really works. However, like most modalities, it's not always the magic fix. But again, what is? But there is good evidence for many conditions. And that was the longest radial shockwave that I got. I don't have focused shockwave, I have radial shockwave. Thank you for listening. I'm just going to hand over to Katie now just to talk maybe around any questions that anyone has, and I'll try my best to answer them as honest as I can.
Thank you so much, Andrew. Yeah, really interesting. I was loving the curveballs as well. They were great. So yes, you did pretty well there, really covering some of the pre-submitted questions, which is great. So I'll run through just a couple of others that might be linked to expand on a couple of those topics that we got through. And again, if you are live, please feel free, if you do have a question for Andrew, just pop it on the Q&A and we'll come to those as well. So the first question that we're going to go through, we received a question about how do you determine the most appropriate cases for integrating both diagnostic ultrasound and shockwave. So I guess around this as well, so would you scan every single patient that comes through, or how do you sort of get that balance when you have those patients in front of you?
Yeah, I think if you don't view diagnostic ultrasound as a separate entity, if you view it as an extension into your current clinical skills. So as I say, I would never use diagnostic ultrasound scan in isolation. It would just be an extension of my assessment. You'll know what's right to scan because you'll want more information on your clinical assessment. So for example, someone's had that inversion injury to their ankle. You've done your test and you're starting to query an ATFL injury. Well, you want more information. So you want to know, is it a full thickness tear? Is it a partial thickness? Is it a grade one thickening only? And we just simply can't get that from our clinical assessments completely. Okay, someone's very lax. You may be able to diagnose a full thickness tear, but you want to see it. So you would use it as an extension into your clinical assessment. Regard shockwave, I think it's good to know when it is indicated, and that's when some training can come in.
Yeah.
Shockwave therapy does fall under the remit of healthcare professionals. However, you have to prove your own competence and your own CPD into shockwave therapy. Um, as a very basic route, I find that it is great for very certain chronic tendinopathies. And as you've seen there from the presentation, had very good results from a calcific tendinopathy point of view as well. So hopefully that answers the question. Please pull me if it doesn't.
And I think before, when there's other scenarios in clinic potentially, maybe more sports related or athletes that are coming through the door, like the use of the diagnostic ultrasound in that scenario, to actually, get the data driven response from the patient as well, like utilizing it in that way. Or obviously you mentioned about actually, you went down a route, but then having to think about a re-diagnosis and bringing ultrasound at that point as well. I guess there are other scenarios, aren't there, that then you've got that, backup of the diagnostic, and then therefore you're on the right route for rehab, aren't you, or having to readdress rehab in some situations.
Yeah, I mean, before I started on the diagnostic ultrasound journey, I had one phrase in mind that when running a clinic, I didn't want my patients to have to take my word for it. So what that means is that I wanted to be able to show the image in the screen, and I wanted to back it up with the data to show where they're weak. And I think increasingly we're in a tech-driven world now where patients are very independent with their own health decisions and independent with their own data as well. So um, I definitely think the more information you have on an injury, the better the buy-in, the better the buy-in to rehab, and quite frankly, how much better you enjoy the job that you have those certainties. I think in physiotherapy, we do pain is complex, and a lot of the time we have to live life in the grey. So it is nice to be able to have more certainty as a clinician as well.
Yeah, excellent. Okay, great. Thank you for that. So on the next question then we have about how does the reimbursement for shockwave work? So I think with this question, and I guess from your perspective, thinking about bringing shockwave into your clinic or into your business, I guess how did you shape that model for people maybe thinking about it? Have you created maybe packages, or how have you started to sort of essentially charge for that modality in clinic?
Yeah, it's always hard to increase prices or charge for our service when we're clinicians, first of all. Um, I know some clinics increase the cost of what they charge for the appointment with Shockwave. I did it slightly differently, just found where we were, it worked better with this way that I did the initial assessment. I didn't have ultrasound at first when I introduced shockwave therapy in clinic. What we did the initial assessment, and as part of that, we have a higher price for initial assessment. So I was happy to include shockwave in their initial assessment if I find it appropriate. However, with the reviews, I shortened the time so that they were coming back for just a shockwave session, which was no more than 15 minutes. And for us, we offer 45-minute review appointments. So I charged the same for less time in the clinic. But if we were running back to back, that actually worked out per hour that we were getting more in. So instead of a 45-minute appointment costing £60, we were able to charge £60 for the shockwave over the next few sessions. And then I might do a longer review again. So the patient actually is charged the same for each appointment, only the time is different. And because we thankfully are generally fully booked, that made an increase into the income of our clinic then.
Mhm. That's a great insight. Thank you for that. Just a couple of questions that's come through live. Does anyone else use ultrasound in your clinic, or is it just you?
It's just me. That's one thing I would say about being over in Northern Ireland. There's not too many physiotherapists at it. I think it will grow over here, and I'm looking forward to it growing in Ireland as a whole. I think it'd be good for the physiotherapy community and other clinicians as well. It's just me at the moment. So I suppose when we introduced ultrasound into clinic as well, it was the education of the staff to know what was appropriate to refer in. And that goes from your other physios you work with right through to our administrative staff on reception who know what is, if patients ring and ask what's it appropriate for, that they're able to tell them. Of course, we'll always give a call back. What we do, maybe not every clinic does this, but if we have had a patient assessed by someone else in the clinic who doesn't do ultrasound, we have an internal referral rate. So basically, the patient pays less for the ultrasound scan rather than if they came to me first, where I can offer it in the first appointment, because technically they're paying twice. So they get some discount on the scan if our other physiotherapists refer in for it.
Okay, great. That sounds good. A couple of other questions again. One that's come through about asking about what ultrasound machine that you do use, which you did cover. So you've got the eCube 8, the cart base. On the back of that question, it was just asked about would it have been better to wait for the latest version of ultrasound when you finish your PG cert? So maybe again, that's just questioning sort of the investment of ultrasound machines, I guess, earlier on in the journey than after the journey. But yeah, I guess it's a part of having to have a machine to learn on as well, isn't it? Would you agree?
Yeah, I've the word of Chris Myers in my head at the moment, who's on the small course that I did, and his first day that we were at his introductory course, this exact question came up. And to paraphrase, well, he said this exactly, actually word for word, but he said, at the moment, you're crap. You're very crap at scanning, and if you buy a crap machine, you're double crap. So it was a big decision from a business point of view. What I would say is, to be honest, try buy well from the start, because in your training you are very vulnerable to making mistakes. We all are, and I'm still making mistakes, but at least the scanner can help you rather than the scanner making it more difficult for you. The cart base worked for us. On reflection, what I've went for a laptop based. Some time to cross my mind. I've seen some of the laptop bases at the courses, and it would be convenient to be able to move it around room to room. We have one clinic, but if we ever were lucky enough to expand into a multi-clinic model, I suppose a laptop based version would be much handier to bring around if you're, say, scanning on a Tuesday in one clinic and Friday somewhere else. I find the opinion very, very good. I've seen them increasingly used more as well. And yeah, the cart base has been good for us. So to paraphrase, try your best to buy as well as you can at the start of your journey, in my opinion.
Yeah, and then we did have a pretty submissive question mentioned about sort of handheld units as well, and then being accurate. So have you had any experience with handheld at all with regards to?
Yeah, again, straight talking, I would say if you want a yes or no question, I would say no. However, I do know that some of the handheld devices are coming on. I think as well, there's something about if you have a patient coming in paying very good money for a scan, they're going to want the best of the devices used. And maybe this is the wrong way to look at it, but even the aesthetics of using a handheld with an iPad, maybe that does look quite well, but I think there's nothing like having a good, decent machine there to back up your clinical assessment. That said, I'll hold my hands up and say I have not used a handheld. They're not using the courses that I attended, and I haven't been in any of the clinics that have used them. So I'll finish like a politician and say maybe there is some scope in certain settings, but I think that if you can buy a laptop or a cart-based one, I think that is a better option, to be straight.
Yeah, I think obviously us working in the industry as well, like we definitely agree, and that is, the feedback essentially that we get from clinicians as well. And there's lots of considerations for when people are purchasing, and that's just got to be right for you. You've just got to openly discuss those, and there's a lot of things that you do need to think about. So obviously if you are purchasing, so we're here as a support, or there's organisations where they can speak you through all those options. But like I say, it has to be the right fit, hasn't it? And it has to fit the objective of why you're investing in that technology as well. So yeah, I think that's really helpful. Thank you. Okay, so I had a question about adapting treatment for athletes with metal work, such as screws or plates. So could you have a bit of response on both ultrasound and shockwave?
Yeah, you can often see plates and screws in diagnostic ultrasound. Of course, it's not the imaging of choice. You'd be more looking at a plain radiograph in that instance. Shockwave would be contraindicated with around sites of metal plates and screws. And there is some evidence to suggest that there is potential loosening effects. And actually, some evidence is out there to say that whenever prosthesis or screws have need loosening, sometimes shockwave has been used in the past. Um, I suppose that's a bit of a negative on both modalities there. Yes, ultrasound is there and can pick up on these things, but I think a different imaging of choice would be better in those scenarios.
Yeah, okay, great. Next question. What are some of the key challenges clinicians and business owners may face? Maybe sort of essentially implementing technologies as a whole or then sort of decision making scenarios.
Yeah, in a word, I'd probably say isolation. Private practices, in my experience, tend to keep themselves to themselves a little bit. And if you're the first to introduce that in your clinic or in your region, you've no one just to, WhatsApp or call upon. However, on a more positive note, I have found the ultrasound community very helpful. There's Facebook groups out there. You meet people at your courses. But that is why one of my points on the ultrasound slide at the last was to get yourself a good mentor. If you're lucky enough to have one nearby that you can meet face to face, that's fantastic. For me, I didn't have that in Northern Ireland, so I had to travel for London to that, which I really enjoyed. Don't get me wrong, I really enjoyed getting over to London. And then more from a virtual mentorship point of view. After that, where I sent over my findings, my images, and then I got some feedback via Zoom or via emails just to see how could I tweak things to improve my outcomes. What other challenges would be faced? I'm tempted to say some pushback from other professionals. I'm not getting at radiology, but I think if you're the first in your profession in the local area to introduce that, are you stepping on toes a little bit can sometimes be fine. But remember, it is an extension onto our clinical assessment. And I think that's where, speaking from a physiotherapy point of view, I think combining that assessment with the imaging is quite a USP that you could have in other settings where they might go for a scan, they'll get the scan and get the results, but it's not brought together with the data from their assessment. You're combining structure and function in your test, and you're testing all of a sudden. So, in my opinion, I think physiotherapy is very well placed for diagnostic ultrasound, and we should continue to push on and support each other. And I think the more we support each other, the less that isolation gets around. And we grow together on a positive note. It doesn't have to be one against the other and out trumping. We're all here to grow together and to ultimately improve outcomes for our patients. So that's what I'd say on that.
That rolls nicely into one of the last questions about sort of how do you see the role of technologies evolving essentially in MSK, but especially in private practice? And obviously you've mentioned about your locality as well, and that's that that evolving sort of awareness, I guess, hopefully for, like I say, that expanded scope with ultrasound especially, being brought to your area, that offerings of opportunities for education as well, potentially, that expansion for that area. But where else would you sort of see things moving or evolving essentially?
Yeah, I think it might stand that we're in an increasingly more inpatient society, aren't we? We want results fast, and I think people are looking at one-stop shop now, where they can come to one place and get total management. I remember being in one course and said another physio said that he feels the holy grail of physio is diagnostic ultrasound, prescriber's course, ultrasound guided injections. Maybe added a fourth, the shockwave as well. I don't inject and I don't prescribe, so maybe that's next to my list to sort of close up that loop. But for now, I'm very happy just growing my ultrasound skills. And again, I maybe get a bit of negative feedback about this, but we can be very injection happy, and maybe some of my slides were there. It's just the ones I picked out. But a lot of things can be managed without the use of an ultrasound guided injection or injection therapy, and very often short term relief anyway, and the long term outcomes are not great. Sorry to answer your question directly. The role of technology is evolving. Yeah, it definitely will. I think the more that is offered across clinics, the more that we all have to keep up with each other. We are seeing, a merging of other professions into the realm of healthcare, especially physiotherapy. I know lots of excellent sports massage therapists who, with respect, have not done the education that we have as physios. And you know what? Their knowledge is second to none. Their injury management is brilliant, as good as any physios I know. So to again end the strong point, I think to keep up, you need to stay up, and that was my view of doing the diagnostic ultrasound. I wanted to start getting a little step ahead. Maybe that's the wrong attitude, but at the end of the day, I'm a business as well as a clinician, and I need to keep striving forward.
Yeah, excellent. Well, that's great to hear. Okay, we've just got the last question, just essentially around shockwave, and any advice for sort of setting up for a small MSK clinic. So we had a question come through as well live about like the best affordable mobile therapy machines. Obviously on the market again, isn't there, like there is with any technology? Has to be the right fit for you when you're inquiring about shockwave or how it's going to fit into your practice, depending on the size. Have those discussions and thinking about sort of, not just sort of upfront costs, but again, the role in maintenance of technologies as well that you want to clarify. So I guess there's those points from my perspective, but general advice, would you say, for like a smaller business thinking about setting up with shockwave, what would you say?
Yeah, very practically, what I would do if I was a small business thinking about shockwave therapy, I buy a little notebook from the shop at 99p, and I keep it in my top drawer, and I just start taking a tally during my clinic over maybe a month period. Okay, if I had shockwave therapy in my clinic, how many patients would I have used it for? And look at that number at the end of the month. And if you do the maths and you say, oh, this is going to be financially viable, well, then it might make the decision easier for you. So if you're going through a run of chronic lateral epicondylitis, patellar tendinopathy, Achilles tendinopathy, rotator cuff calcific tendinopathy, and you think, I could have used it for that, and that, I think the numbers will speak for themselves. You will make money back on shockwave, on radio shockwave. I would say, regards the devices, do your research. I have found the longest power shocker very good, low maintenance. The training is available there. I know yourselves run an online course as well for groups, but at the end of the day, if it isn't going to pay, it's not worthwhile introducing it unless you are maybe not as business focused and you're all about patient outcomes, which is great. And if your questions about outcomes for patients specifically, well, yes, you can think, well, what would it change the outcome of this patient? I think there's a fine balance, isn't there, between improving patient outcomes and having the business plan to back it up as well. Because at the end of the day, life is getting more expensive. Clinic costs are getting more expensive as well. And insurance companies don't seem to want to pay us very much money, more money than what they currently are. So, and maybe picking up on that as well, a lot of insurance companies don't cover shockwave as a standalone treatment. That might be one challenge you might face in your clinic. And I suppose it's the patient, managing the patient expectation there as well, that won't be offered as part of your health insurance session there, if that's the route they're going down. And I think Bupa does. I need to look into that a little bit more. So yeah, that's what I'd say, Kate.
Yeah, excellent. I think you've raised some really important points there, so thank you. And I think we've got through all the questions. Yeah, we've got some people saying thank you on the live feed. So yeah, they've gone down very well there. Thank you. So let's just close up the webinar then. So with that, thank you, Andrew, very much for presenting for us today. Like I say, it's such valuable sort of insight, like I say, to see not just case studies, but your perspective on things. Yeah, I think it's great for everyone to be hearing about. So following today's session, we will send everyone the recording as well, so you can look back on the webinar. And yes, for those who didn't live as well, you will receive that. If you do want to get in touch with us directly about any sort of shockwave machines, ultrasound machines, or further education opportunities, please don't hesitate to contact us. You can contact us by email or give us a call. We're happy to discuss any queries, any thoughts around sort of implementation of technology, or even being part of education. So with that, thanks again, Andrew, very much for taking up your lunchtime. Hopefully you've got some food now that you can go to.
I think I might just. Yes, thank you, everyone. And thank you, Katie, for hosting as well.
Perfect. All right, thanks everyone for joining. And yes, I hope you all have a good rest of the day. Take care.